Good morning, everyone, and welcome to Medicine Grand Rounds. I'm filling Errol's big shoes today. It is National Breastfeeding Awareness Month, and we're going to kick it off with a great talk by Doctors Buesing and Crowe. But first, we have a lot of updates to get through as there are a lot of moving parts with respect to the COVID pandemic. So we will start with our usual updates, and I will just hand it over to Dr. Pinsky. Thank you.
Thanks, Tamara, and good morning, everyone. I will give the variant update as usual. So just a reminder, all the samples positive for COVID-2 in the clinical virology lab get screened for variant-associated mutations. Those are shown below here. And N501Y, E484K, and L452R, which you all have become extremely familiar with over the last year or so. Both positive and negative screens are sequenced, whole genome sequenced in order to identify the lineage identification, including the variants of concern and interest shown here, alpha, beta, gamma, and delta, of course. We're working on a second RT-PCR to give even more confidence in our variant calls that will include the underlying mutations here and help us further distinguish between variants of concern and variants of interest. So again, delta is what's on everyone's mind. This contains L452R and T478K mutations. We've also seen a small number of A2.5 mutation of lineages, which also contain the L452R mutation. When we sequence these, about 94% are delta and a smaller percent are A2.5. If we look at our epidemiologic curve, you can see a dramatic increase in the number of samples positive and genotyped here from last week. Nearly all contained the L452R mutation, and so are the Delta variant. So consistent with global and the rest of the United States, we are seeing a predominance of Delta. Our overall 7-day positivity rate for testing is right around 4%, which is similar to what we saw last week. So that's my update for this week, and happy to take any questions in the chat and Q&A. Thanks a lot.
Thank you, Dr. Pinsky. Dr. Collins.
Yes, let me just get this pulled up. So I'll update on our inpatients with SARS-CoV-2 at Stanford. If I can advance my slides, there we go. I think a lot of people have seen this chart in various communications, but as we know, hospitalizations continue to rise in our area, leading recently to the indoor mask mandate that was just issued in the last couple of days. And for our own hospital system, we had talked about potentially this peak in the third week of July with some downtrend after, but it looks like that was more of a lull, and we have seen cases and hospitalizations continue to rise. As far as demographics, we've had 85 adults now hospitalized within 14 days of a positive test in July. 61 of those at Stanford Hospital, 24 at Valley Care, and 6 at a labor and delivery unit. About 60% are male. Predominant race or ethnic background was white or Latinx, and the age distribution more in the middle to upper age range, but fairly wide as well. 55% were not fully vaccinated, 6 pregnant, although all with mild or asymptomatic. 27 individuals had been immunocompromised, 3 VT events, that's not new, and then 2 deaths still. 1 was not related to COVID. As far as the variants of those that have been able to be typed from these patients, about 92% were presumed or confirmed Delta. And then as far as severity, we kind of have 2 big groups, either those who are asymptomatic or mild symptoms, probably hospitalized for something else or because they were high risk, and then this group of severe and critical patients. And you can see the breakdown of those that we could identify as vaccinated or unvaccinated. Still, a good majority of those who are severe or critical were unvaccinated. Of the 11 that were vaccinated, at least 9 had some sort of pretty significant underlying condition that put them at greater risk. So again, cases continue to rise in our area and at our hospital. Of those with severe or critical COVID-19, 68% were unvaccinated, with the vaccinated folks, at least 9 of them having a significant comorbidity. So thanks to everyone who helped with these numbers.
Thank you so much for that. Clearly, the COVID situation is quite dynamic, and we appreciate everyone's patience and understanding as we move the needle as the situation changes. So just wanted to give everyone a quick reminder about grand rounds for next week, and I'll tell you about it as soon as I see it. I believe we're talking about COVID variants, if I'm not mistaken. Aha, yes. And we'll have Doctors Rustagi, Pinsky, and Schaefer giving an update on the variants, followed by some vaccination public health campaigns that will be led by Dr. Linos. And then we'll talk about some legal aspects of COVID vaccination and community mitigation orders the week after that to round off the month of August. So let's get to today's grand rounds. On behalf of the Department of Medicine's Diversity and Inclusion Council and our Inclusion 2021 series, I want to welcome you to a talk that will celebrate National Breastfeeding Awareness Month and will teach us something and help us as a community be more inclusive and supportive of breastfeeding and chest feeding people. We have 2 amazing speakers today who will answer the question, got human milk? Dr. Jessica Buesing is a chief resident in the internal medicine program here at Stanford. She grew up in Palos Verdes, California, and then attended Williams College, where she majored in music and psychology. She later realized medicine was her calling and attended the Columbia University Postbac program and earned her medical degree from Columbia University's Vagelos College of Physicians and Surgeons. During her time at Stanford, she has been a member of the GME Women in Medicine Leadership Council and is an advocate for diversity, equity, and inclusion in medicine. She has 2 children, aged 4 and 1, who take up all of her time outside of the hospital. We're also pleased to welcome Dr. Susan Crowe. She's a clinical professor of obstetrics and gynecology and the director of the outpatient breastfeeding services at Stanford. She received her medical degree from Loyola University of Chicago, then pursued residency training at Kaiser Permanente Santa Clara. She is a fellow of the American Congress of Obstetricians and Gynecologists and a member of the Academy of Breastfeeding Medicine. She has authored committee opinions for the ACOG, including breastfeeding challenges, as well as optimizing support for breastfeeding as part of obstetric practice, and has been one of the leads of the recent Stanford Breastfeeding Task Force. We are thrilled to welcome them both to kick off National Breastfeeding Awareness Month. Thank you. Welcome to both Drs. Buesing and Crowe.
Thank you. I am going to share my screen and give me just a moment to pull up my slides here. All right, so we're so pleased to be here today, and I appreciate all of your joining us, and welcome as we celebrate World Breastfeeding Week with this Grand Rounds. As a way of giving you some background, World Breastfeeding Week is celebrated every August 1st through 7th in commemoration of the 1990 Innocenti Declaration, where the World Health Organization, UNICEF, and other global organizations signed a document to set an agenda internationally for the protection, promotion, and support of breastfeeding. The theme of this year's campaign is Protect Breastfeeding, a shared responsibility, and aims to protect lactation at all levels. I want to say a word about the language that we use here. I'd like to acknowledge that not all people who give birth and lactate identify as female, and that some don't identify as either male or female. And as we communicate about lactation today and elsewhere, people will have various preferences. At Stanford, we aim to model inclusive language, and we also acknowledge that at global and national levels, many times gender inclusive terms have not yet been incorporated into these communications, especially as they may be translated into other languages. But I'm going to introduce some more inclusive terms, such as using the words breastfeeding and chest feeding, as these terms communicate the direct feeding of human milk. Lactating person may be used instead of mother. Human milk or milk may be used instead of breast milk. I will refer to breastfeeding today as it refers to references that I've used and sources of information for this presentation, but otherwise I will attempt to use language that supports the inclusion of all lactating people. So here we are also, as we see here, celebrating National Breastfeeding Month with a theme of every step of the way. And this has the mission of envisioning and creating a world in which every family and every person is supported every step of the way in their lactation journey. And in line with these themes, we will share today about how we can create an environment together at Stanford to facilitate these goals. I'm going to skip through this in the interest of time. To give you some background, Stanford Medicine has made a commitment to creating a workplace where all members of our community can thrive and ensuring the right resources and support for our faculty physicians, scientists, physicians in training, medical students, et cetera, who belong to our community. We understand that providing these lactation resources are critical to fulfilling that goal. Many parents at Stanford are returning to work soon after giving birth, and they may want to continue with their lactation journey. And in response to concerns from the Stanford medicine community about the lack of lactation accommodations available, Dr. Tate Shanafelt, our Chief Wellness Officer, commissioned this lactation task force to assess the current state of lactation culture and support at Stanford, and to make both near and long-term recommendations for improvement. I had the opportunity to co-chair this task force with Dr. Leslie Subak, who is our chair of the Department of Obstetrics and Gynecology. This task force membership included people from a variety of areas so that we can incorporate feedback from clinicians, scientists, medical students, and others in leadership who could give input as to identifying the needs and how to address them. I'd like to give you a little bit of background about breastfeeding rates and culture just in our society in general. These are rates reported as breastfeeding rates by our CDC. And I have up here the most recent data at the time of preparing this slide a week ago for 2018 data. And you can see that breastfeeding rates have significantly increased over the past 20 years. And so more people are needing support in meeting their lactation goals. Infants born in 2017, 58% were breastfeeding at 6 months, and more than a third were up from 35%, in 2000. More than a third were breastfeeding for 12 months. And so we can see that more and more people are choosing to continue lactation after they return to work. You can also see here that there are disparities in non-Hispanic Black population in specifically, which I'll address a little bit later, as that contributes to disparities in health outcomes. The CDC did just release this 2018 data a couple of days ago, and the overall rates have remained stable in the past year. There have been significant efforts on a national level to improve outcomes in non-Hispanic Black communities, and we've seen a slight increase. For example, breastfeeding at 1 year is now at 28% for non-Hispanic Black communities, and so that's up a little bit. This here is a survey the CDC puts out periodically for hospitals, asking them about the maternity care practices they provide to support lactation. And you can see here that There's been significant significant change in the way we initiate lactation and support it at birth in this country, where 83% of hospitals are now routinely offering skin to skin so that lactation can be established immediately after delivery. And 83% are offering that in their most recent survey, and 55% are offering rooming in. These are known to be supportive maternity care practices. Of note, however, in a report put out by the CDC in their MMWR, their Morbidity and Mortality Weekly Report in August of 2014, that people living in zip codes with higher percentage of Black residents have less access to these maternity care practices, setting the stage for disparities in lactation outcomes. So much work is still to be done on a national level. So why are we talking about this? Why does this matter? From the public health perspective, we know that there are known improvements in health outcomes for child and maternal outcomes. Some of these here are listed on this slide. And this article referenced below estimates how these disparities in breastfeeding have an impact on maternal and child health outcomes and costs. And for example, compared to non-Hispanic white populations, the non-Hispanic Black population had 3.3 times an estimated number of excess cases of necrotizing enterocolitis and 2.2 times the number of excess child deaths due to suboptimal breastfeeding in a year. And the Hispanic population additionally had 1.5 times the number of excess deaths. This in part may be due to even more impactful because of the fact that there's a higher preterm birth rate in Black communities, and that would also contribute to a higher risk of necrotizing enterocolitis if fed human milk substitutes. As an obstetrician, I think it's important to also, I've highlighted a few of the maternal health outcomes that set the stage for a lifetime of health outcomes that I thought in particular this audience would be interested in. There's a relative risk of breast cancer decreasing by approximately 4.3% for every 12 months of breastfeeding. It's also very impactful on the lifetime risk of type 2 diabetes. So we counsel our patients with gestational diabetes who may be at especially high risk for type 2 diabetes, that by breastfeeding for 1 year, they can reduce their risk of type 2 diabetes by approximately 44%. And if they breastfeed for 1 year between two children, they still have this benefit, slightly lower though, at 24% reduced risk. And another article estimates 9% reduction of relative risk for each 12 months of lifetime duration of lactation. Women who breastfeed for 5 months had a 30% decrease in the risk of coronary artery disease in this article. So these are things that can set the stage, and it's a critical window that we support people in their lactation choices. As a result of these findings, the AAP and ACOG recommend exclusive breastfeeding for about 6 months, followed by continued breastfeeding as complementary foods are introduced during that second 6 months of life for the infant, and then for thereafter, as long as mutually desired by mother and infant. And when I'm referring to the addition of complementary foods after 6 months, there's not a specific recommendation that any other milk be introduced. So it's still a recommendation of human milk being the exclusive source of milk during that first year. And just to clarify that, because some of this terminology can be confusing, the World Health Organization has recommended a minimum of 2 years, and we are likely to see adjustments in our national organization recommendations to reflect the mounting evidence to support breastfeeding, to support lactation for at least 2 years. In terms of I'm going to talk a little bit about some background now about why and what the lactation task force findings were, and then we'll address culture and recommendations at the end of this talk. But to summarize, the lack of lactation support may lead people to make a difficult choice between meeting their professional commitments or meeting the needs of their families. And this can have long-term consequences on the careers and of individuals, with consequences associated with long-term gender inequities in the workplace if professional or academic activities are postponed or abandoned. Again, we also see benefits from an organizational standpoint as a whole. As we support lactation, we see improved productivity, loyalty, public health image, or public image, as well as we all actually benefit tremendously from the decrease in healthcare costs and insurance costs. And we often think of lactating people as doing something for their families, but I'd like to emphasize that they're actually doing this for all of us, along with some of these other things. This is an important intervention to reduce the leaky pipeline that, as I mentioned before, contributes to gender inequities. We've also noticed, and in general, people who have a college degree have been found to have the highest rates of lactation. And so this is a slide demonstrating a study that showed how physicians are actually not included in that group, and that they have particular difficulties continuing to lactate for that first year of their infant's life. And many have cited typically extended work hours, the predetermined schedules. It can be difficult to schedule in time for lactation. They may be going to different places every day as they express milk in different places. It can be hard for them to make those accommodations for themselves, and typically don't have scheduled breaks in their workday, contributing to these differences. So this task force began a year-long journey last May of 2020, seeking input from colleagues to understand our current state, gaps, and opportunities. And it also assessed resources available at peer institutions, which helped to gain a clearer view of our opportunities to improve lactation support here at Stanford. We found in the task force that there was insufficient lactation space the rooms are not available in all the locations that are needed, as well as you can see here in this picture, people are finding and making lactation spaces of their own. They may go looking to how to create that. We also found many of the members of our task force discuss the need for computer workstations and other things so that they could continue working as they express milk during their workday. Also found insufficient time. So current time allocated for lactation was insufficient to meet the needs of many lactating people, especially in the clinical and research environments. In particular, people who are paid based on work RVU compensation models may suffer related to trying to meet those goals. And there's just no system for knowing. People may be running between OR cases, and they may have difficulty knowing which room is available for them, and they have to run from one room to another in a very limited time frame. We also found lactation culture challenges exist, and we'll talk about some ways that we've recommended addressing these today. People felt like there was just a lack of broad awareness about what the lactation needs are of their colleagues, and there's a lack of education regarding this process. People have often reported feeling stigmatized, finding intolerant work notes left at workstations, being told to remove their milk from staff refrigerator, and other incidents that we believe should never occur in our environment. And in addition, there were no regular formal assessments of our lactation needs here. So in terms of additional information about our culture in medicine and at Stanford, I'm going to turn things over to Dr. Buesing to give us her insights.
Thank you so much, Dr. Crowe. I am really honored to be here to get to take part in this conversation today. This is a topic that I feel deeply passionate about, and I'm really thrilled to be able to share my perspective today with you all. As part of my time at Stanford, as mentioned earlier, I've been part of the GME Women in Medicine Leadership Council for the past few years. And we've had several events and have had many conversations amongst ourselves about topics related to this that I think tie in very closely with this issue, including things like the pressures of parenting while in the medical profession, the challenges of pumping at work, delayed childbearing amongst physicians, and the higher rates of infertility within our field, and many other important topics. And my residency senior talk last year was about family planning challenges for trainees, and part of my talk focused on the immense time commitment and cultural challenges of breastfeeding. And so, the discussion today feels a little different than many of our grand rounds in that we're talking about a shared human experience of many of our trainees, our faculty, and our staff here at Stanford who have been navigating lactation at work. And I hope that what you'll take away from this after hearing me share my experience and hearing Dr. Crowe speak about the lactation task force is that the culture in our field and the logistical challenges of lactation, particularly with regards to having adequate time and space to pump, can truly be improved. And so with that, I'll tell you a little bit about me. I got pregnant during my third year rotation of medical school. I took step one when I was 33 weeks pregnant, and I had my first child during my fourth year, not too long before starting my residency application process. And, one of the things that really struck me early on in my parenting journey was how frequently I heard comments, which although may have been well-meaning, I found truly disheartening. This was particularly relevant when I was traveling around the country with my 6-month-old son to interviews, and I had to pump during my interview days. And so on this slide, I was sort of reflecting on some of the things that had been said to me. And I think a lot about how much the words that we use carry a lot of weight when we are talking particularly to mentees and students. And, examples of things that I heard were, don't tell interviewers that you have children. It will hurt your chances of matching. And what I heard when I was, listening to these comments was that I have to keep my family a secret. And I heard reminders that, interviewers are not allowed to ask if you plan to have children, and this is to protect you. So don't offer up this information, which made me feel like I am not welcome in medicine for having a family. And then particularly with regard to lactation, if you have to pump on your interview day, discreetly ask the residents where to go. Don't tell the program, don't ask the program directors. And what I heard from this was that I have to navigate this alone. And I also heard comments like, it's hard to do well in academic medicine if you have children. And this made me wonder, am I good enough? And anecdotally, many of my colleagues have been told that we should not have families during training. And this has been said both explicitly and also implied in messaging. And the messaging is often that it will get in the way of our careers. And I would argue that this language really sets the tone for the entire profession. If we tell medical students, residents, fellows, faculty that they should postpone having families or that they should have to hide that they're lactating, I feel like we are contributing to generation after generation of physicians feeling like they're forced to decide between having a fulfilling family life and being an excellent clinician or researcher. On my interview trail, I thought it was exceedingly important for me as a human and as a professional to disclose that I was a parent and to ask very directly of programs what they were doing to support their trainees who were parents. And my experiences were very telling. Some programs offered for me to pump in a public classroom with windows overlooking the hospital hallways. Some offered me a space in a closet or a private office. One offered me space in a locker room. And these were excellent programs in internal medicine, and many did not have the infrastructure to support pumping. And so I just want to highlight this because this problem is clearly ubiquitous and is a real issue. And as a medical student, I also found it was very hard to talk about breastfeeding with people. Telling attendings that I needed to pump felt sometimes embarrassing, and not because I was embarrassed, but because it seemed to make people uncomfortable. And I have heard this from others as well. And this was really surprising to me that in a field where we know and understand the human body so well, that the most natural biological process felt taboo to discuss. And I felt I would have attendings turn away from me saying things like, oh, sure, whatever you got to do. but it needs to be okay for us to talk about this openly. Next slide, please. You know, one of the most challenging things about breastfeeding, and one that I want to highlight during my portion of this talk today, is that it takes an immense amount of time and energy. When I came back to clinical rotations during my 4th year of medical school, for example, I was pumping about every 4 hours, or at least trying to. And what this entailed was leaving rounds, running to another building to grab my belongings because I wasn't able to store them in the hospital. I would run to then yet another building to find the lactation room, which was hopefully open. I would pump for 20 to 30 minutes. I'd run back to put my things away after washing my pump parts, and then I would go back to rounds. And this process took me over an hour almost every time. And so you can imagine that this is not compatible with being a working professional, and it put a tremendous burden on me. The logistics were completely unreasonable, and as such, I started skipping pumping sessions. And this led me to get really severe mastitis, and I was septic. And so what I want to emphasize here is that pumping is not a luxury, it's a medical necessity, and it's inconvenient, and it can be extremely stressful. And so we need to be supportive. With my second child, my daughter, who I had during residency, I came back from maternity leave, and the proximity of lactation spaces really depended on the rotation that I was on. Some of them were not quickly accessible. Others were more close by, which made for a relatively quick transfer between locations, but only if the room were available. But what I frequently did not have access to was a computer when I pumped, so I couldn't get work done. And as you all know, the work does not go away. You just have to push it until later, which meant leaving later and spending less time with my newborn. And I found that by the end of the day, I was completely exhausted, chronically underslept. And at times I felt, truly despondent about this. And so, one day I was looking up ways to become more efficient at pumping, and I came across this quote that you see on the screen, which is that breastfeeding for 1 year is approximately 1,800 hours. And if you compare that to a full-time job with 3 weeks of vacation, it's 1,960 hours. And I thought to myself, can that be true? Am I doing almost a full-time job on top of residency? And so I decided to sort of calculate it out for myself. Next slide. So a newborn baby nurses on average about 8 to 12 times in a 24-hour period. And these sessions, depending on the baby, can last around 20 to 60 minutes each. And at 12 weeks, when I returned to work, which by the way was a much better leave than many places give their trainees, my baby was nursing around 8 to 9 times per day. And each nursing session took me roughly 30 minutes. So you estimate around 4 hours. But pumping took much longer than that. I would spend at least 45 minutes to get my belongings, go find an open lactation room, clean up my pumping supplies, which required often going to a bathroom, a break room, or a kitchen to find a sink. I often had to pump during rounding time, so I would have to leave rounds. And I would try to pump 2 to 3 times at work each day, depending on the length of my shift. And sometimes on 24-hour shifts would have to throw out pumped milk because there was nowhere for me to store it. Many people pump every 3 to 4 hours to keep up their milk supply and prevent mastitis. So this is very much in line with what we would expect for somebody who needs to pump if they're trying to pump for up to a full year. Next slide. And in addition to the actual pumping and nursing time, cleaning and sanitizing pump supplies is also extremely time consuming. And so I would get home at night, I would nurse, I would clean the pump parts, I would sterilize them, I would pump again. And this took sometimes about 2 hours. And as you can imagine, during my time during, for example, the COVID ICU, I was particularly worried about sanitation. So really wanted to make sure I was sterilizing those parts. And so for me, this averaged out to about 4 to 5 hours a day of nursing, pumping, and cleaning, which, is about 28 hours a week. And that calculates to about 1,456 hours a year, which is not too far off from the estimate that I read online. And this was with supplemental formula because I truly could not keep up because of the demands of the job. And so to lay this out for you and to what this looks like, there are 168 hours in a week. And if you work 80 hours a week, like I did on some of these longer rotations, and you're pumping and nursing for 28, some of that being done at work. But like I said, the work doesn't go away. So sometimes you're staying longer to finish. And if you're trying to sleep for around 7 hours a night, which for those of you who have had children know that does not happen with a newborn, you're left with about an hour and a half a day to do anything else, like get ready, shower, commute, brush your teeth, eat. And so sleep is the first obvious thing to go. So to give you an example, when I was on my ICU rotation, I would wake up at 4. I would nurse my daughter, I would pump, I would get to work by 6 a.m. and take sign out, round, pump again around 10. I would try to eat lunch the same time as I was pumping at around 2 p.m. And because sign out in the ICU was at 6 p.m., I would often skip my 3rd pumping session in order to get home, which would often delay nursing or pumping, which would lead to clogged ducts and 2 episodes of mastitis that required antibiotics and sick days because I was so ill. I would get home sometimes around 7:30 or 8 p.m., then nurse my daughter till around 8:30, clean the pump parts, sanitize them, then pump, then clean the pump parts again, and then pack everything up for the next day. I would scarf down some dinner and go to sleep around 10 or 11 at night, often wake up and nurse my daughter around 1 a.m., and then wake up at 4 a.m. to do the day all over again. And the reason that I am emphasizing the amount of time that this takes and walking you through in such excruciating detail what my days were like is that because it demonstrates what an incredible challenge it is to nurse and pump for a full year under any circumstance, but particularly when we are working in a time-intensive field like medicine. The only way that this becomes feasible is with a tremendous amount of support from our colleagues and from our institution. And creating a culture that is accepting, welcoming, and supportive is paramount. And what I've heard from several of my colleagues who've pumped at work is that the system feels loosely supportive. Yes, there are pumping rooms, but that is not enough. There are no sinks in the pumping rooms to clean supplies. There are no refrigerators for milk storage. There's, oftentimes not very much space in the break room fridges. There's no computers for doing work, and people often feel like they're truly alone in navigating this. And talking about breastfeeding with colleagues can feel uncomfortable, and it is isolating. The best experiences that I had as a trainee navigating lactation were when attendings would go out of their way to say, Jessica, is now a good time for you to pump. Let's go see your patients first so you can step away. Or things like, let me cover the rapid response pager while you're pumping. And little gestures like that made a huge difference for me in easing the burden. Next slide. So we're including this photo just to give you a sense of what happens when people are not able to express milk regularly, which is that mastitis is an extremely painful and often pretty intense infection. And so just to give you that example of how important it is for people to be able to pump regularly. And so I'll pass it back over to Dr. Crowe to talk about the task force recommendations.
Thank you so much, Dr. Buesing, and for giving us a clear idea of what lactating people are going through, experiencing, and what their needs might be as they navigate return to work and lactation. So as a task force, we developed recommendations to provide a clear path toward creating an environment to better support our colleagues throughout their lactation journey. The recommendations were broken down into targeting certain groups, and I'm going to highlight those they will be broken down in those categories. So to our facilities leadership, both at Stanford Healthcare, Stanford Children's Health, and the School of Medicine, we recommended that there be an upgrade of all currently allocated spaces to meet standard amenities categories. And you can see the full report. We have a link at the end where you can see a summary, and there will be a full report available as well. But just to let you know, standard amenities, we have included a hospital grade pump to be available in the rooms. Some of the rooms we have also recommended, particularly where physicians or clinicians are likely to want to continue work on Epic, we've recommended that computer workstations be provided so that they can easily continue that work while they are expressing milk. We've also recommended designation of incremental lactation space in targeted areas where there has not been found to be adequate lactation space currently. And we also recommended that we promote communications, both from the human resources across the organizations, at least annually, to assess the current room availability, because there often were more spaces available than people were aware of. We also are recommending that we access some type of technology. There are various modes available where we can optimize lactation space room management across our enterprises so that people will be able to look and know before going to one of the rooms where available sites are for lactation space in real time in terms of availability. And we've also recommended that a lactation champions program be established. We're asking chairs to assign a volunteer lactation champion from each department or division for the larger departments, such as the Department of Medicine. And this lactation champions program will have the responsibility of meeting quarterly to discuss a School of Medicine and formulate a School of Medicine-wide general lactation support plan. They will problem solve and escalate problems to leadership that they see as needing to be addressed. They'll also develop a program-specific plan so that when medical students are rotating through or other colleagues within their program are lactating, they will be able to develop a plan for support. There's also a recommendation that there be communication to human resource leaders and communication teams to expand a communication strategy and foster an open culture of communication around lactation, and also to ensure that all of our human resources leaders are aware of what people need in order to support lactation. There's also a recommendation that we establish a system whereby value of lactation time is credited so that lactating people are not experiencing a pay reduction or having to stay late to meet their clinical commitments while lactating during the first year after their infant's birth. I'm really pleased to say that executive leadership across our enterprises have been strongly supportive of these findings and recommendations and are in the process of evaluating ways to operationalize these recommendations. I think that valuing this lactation time is a very big step, the details of which are somewhat complicated, and we won't see this as more of a longer term recommendation, but we're very, very pleased to see how well embraced these recommendations have been. We'd also like to, we've also recommended that there be an addendum to visitor exception criteria so that people can directly breastfeed when they are either working a long shift or in a situation. We also want our patients and families to be able to continue lactation and to not have any barriers there from an institutional perspective, and to not we're recommending that time limits not be imposed at 6 months, as we've seen the recommendations are to continue lactation for at least 1 year. So I'm going to turn this back over to Dr. Buesing. Oh, one slide first, sorry. As we look at how to address our culture at Stanford, this is a CDC culture survey about whether or not we're comfortable with lactation. And this question was asked where approximately a third of people don't agree that they're comfortable when people breastfeed near them. And many of us have lived in a culture where lactation was not the norm, and recognizing our own biases, we may also have biases about the professional nature of commitments in terms of families, some of which Dr. Buesing addressed. already, and just recognizing that these are our own internal biases will help us to address the culture as well. Okay, Dr. Buesing.
Thank you. So I just want to say thank you so much for listening. Like I said, it's a privilege to share my experience and to outline some of the challenges that I and many of my colleagues have faced in trying to navigate lactating at work. And I feel that this is really a tremendous opportunity for cultural growth and for infrastructure to be put into place to truly support the needs of lactating employees. And so I want to share some of the things that I thought, easy things that we can all do as individuals to sort of help expand this culture of support and acceptance, including things like, if someone on your team is pumping, help them find times throughout the day to step out and pump. Don't shy away from conversations about lactation and pumping. I think many people feel really lonely navigating these challenges by themselves, and being able to talk about it with others can be helpful. And I certainly found it to be helpful to talk about with some of my other colleagues, particularly those who were also going through it, but even those who weren't. I would encourage people to feel comfortable pumping in team rooms. Some of my colleagues have mentioned that if they couldn't pump in their team room and have that convenience, that they would not have pumped and nursed their child for as long as they did. Using supportive language, including acknowledging the tremendous work they're doing to nourish their child, and giving them credit for doing that, because it really is a Herculean effort. And the last thing I want to point out that I think is particularly important is I think about this obviously from the having been a medical student interviewing for residency, but I think this goes for interviewing for any position. Asking someone's plan for having a family is certainly fraught and has a lot of implications. When you ask somebody, are you planning to have children? Do you have children? I would say that instead of doing that, we should preemptively tell interviewees what our program or department or group does to support parents and lactating family members. And if Stanford wants to recruit the best talent, we really need to consistently create an inclusive and supportive environment for parents and truly for everyone. So thank you again. I'll pass it to Dr. Crowe for a few finishing comments.
All right. So one of the culture recommendations in the task force report is to offer grand rounds every 2 years approximately in each department to share lactation specific topics of interest for different departments. And I really want to extend my gratitude to the Department of Medicine for being the first to embrace that recommendation and inviting us here today and taking that big step in improving our culture here at Stanford. We all have a role to play in creating an environment that is innovative, inclusive, and attracts both the most talented and committed colleagues. And we believe together we can drive this change. Our institutions at Stanford will become models of outstanding lactation support where all families can thrive. There are opportunities here in this slide. There's a link where you can find task force findings and recommendations. And there's also an opportunity there if you want to communicate with us regarding these findings and recommendations. We look forward to participating with all of you. And we really thank you for your attention to this initiative. Please put any questions and answers in the chat. We've left about 5 minutes for those questions, and a couple of which we have answered. Dr. Dunn, do you want to look through any of these? I answered a couple at the beginning. I don't know if there's...
Yeah, sure. Well, first of all, thank you so much for an amazing talk. I really think that, this is such an important topic, and I love, as a breastfeeding parent, not now, I have, I really just think that this culture change is is going to be so important. And, as a program director, I feel that there's something that I can do right now. I mean, we've always been a supportive program, but I think even writing in an interview invitation, please let us know about any lactating people so that we can make accommodations and arrange your day appropriately. So I wanted to ask one question about how you support people that are having trouble breastfeeding, especially, and we are talking so much about breastfeeding and chest feeding, and all of the recommendations are to, to have human milk be the milk for infants for a year. How do you support those people that have trouble? Because it just doesn't happen for some.
Can I clarify? Are you asking about supporting people with breastfeeding initiation, or supporting people when they return to work and they're experiencing a drop in supply or other complications?
Mainly with initiation. I mean, I feel like a lot of my friends personally have just had trouble and not been able to keep their milk supply up, and that's been for various reasons. And then they feel very inadequate, and I think they have a lot of shame.
Mm-hmm. Thank you for bringing that up. One of the comments I'll have regarding that is, although our maternity care practices have improved, we still have a long ways to go in terms of helping people support lactation initiation. And that's something that as a healthcare system, we're addressing and making improvements on. But there are also many people who struggle for a variety of reasons with the initiation of lactation. And I think that, it's important to emphasize that people need our support regardless of how they feed their newborn, and the emphasis on feeding, on lactation has improved outcomes, but I do think it's also put on a significant amount of stress for people who aren't able to fully establish lactation. And I think recognizing that struggle and referring to lactation specialists, there's probably an hour-long talk I could give about what interventions could take place, but we certainly want them referred to specialists who can help them. And this also is partly tied in with the maternity leave, which we did not address in our lactation task force, but maternity leave is the length of maternity leave may also relate to the ability to fully establish lactation, especially as many of our residents are returning to the workplace in 6 weeks. The fully established milk supply often won't be established until 12 weeks. And so they're in a position of needing to pump in order to work towards that lactation establishment, which can be particularly challenging. And that's a very important topic as well.
Great, thank you. And Mira Sheffrin had asked, what is the timeline for implementing the task force findings, especially adding and upgrading current lactation rooms?
So I'm pleased to hear Dr. Shanafelt has been coordinating much of these near-term recommendations, and I'm pleased to hear that facilities is in the active phase of planning upgrades that are recommended to the lactation spaces. And so many of those are short or near-term recommendation and goals. We won't be able to install plumbing in them, but we will be providing sanitizing methods and refrigerators and other things in the near term. So we look forward to those changes. Other changes such as the work RVUs will take some planning and coordination and some conversations regarding funds flow. And those will be, I anticipate, taking a little bit more time. But we will be asking chairs of departments to appoint a lactation champion from the department and initiate the lactation council in the near term as well. So some of them near term, some of them longer term.
Great, thank you. And Shaylee Merlo had a question about any thoughts about giving lactating parents better parking options, talking about being exhausted, dehydrated, walking to sea lots at very late hours.
It's funny to me because this is a suggestion that I have had for years that could save the time that it takes for an entire pumping session, right? So I appreciate that. Parking is a complicated topic at Stanford, as you can imagine, and it involves different organizations and different coordination efforts. And currently that is not in the lactation task force report recommendation, but I appreciate that. And there may be other implementations in the future. And certainly you bring up a very important point. So thank you.
Great. Well, it's just after 9 o'clock. I just want to let you both know, Drs. Crowe and Dr. Buesing, we really appreciate your talk today. There have been a lot of positive comments, people just saying thank you. I've already gotten emails saying this was a wonderful talk to give. So I really hope that it is going to help us be on the road to changing our culture in supporting breastfeeding people and chest feeding people. So thank you so much. And thanks everyone for attending. We'll see you next week.
All right. Thank you.
Thank you. Thanks for having us.
Thank you.
Thank you all so much. That
Oh,
was-
Dr. Dunn, I apologize if I didn't refer to you as Dr. Dunn.
Oh, no, you did.
Break. Oh, did I say Dr. Dunn?
You sure did every
Okay,
time. It's
good.
fine. Thank you. Oh my goodness. That was
Um,
amazing.
Well, thank you all. And this was such a great, oh, good. Yeah, no, thank you all for having this opportunity today and really for being the first ones to step up and have a grand rounds on this topic. So really appreciate this opportunity. And thank you, Dr. Buesing.